So Dr. Whitmore's dilemma was, as I said in my talk about screening, is cure possible when it's necessary, and is cure necessary when it's possible? As we know, only a small proportion of men with prostate cancer die from the disease. And we know that if we treat those, that the morbidity from radical prostatectomy and radiotherapy is worse than active surveillance. And that's what we did back in the days. 10% of men with low-risk prostate cancer only received active surveillance. But those numbers have started to change, so it's now about 44%. And this is thanks to the father of active surveillance, who's here in the audience, Dr. Lawrence Klotz, who coined this term early in the 2000s. And now this is data that I got from Matt Cooperberg a few weeks ago. 55% of men in the AQUA registry here in the US now go on active surveillance who have low-risk disease. And check out Sweden. I think we are world leaders in active surveillance. For very low risk, the number is now 91%, and low risk, 74% of men choose active surveillance. And we know that the data, the long-term data, demonstrate that active surveillance is safe. We have data from Hopkins and Toronto and many other cohorts around the world. We also have the data from SPCG4 that now has 29 years of follow-up that shows that if we treat clinically detected localized prostate cancer with radical prostatectomy, that confers a survival benefit. But for screen-detected prostate cancer, or in the PSA era, the PIVOT trial did not show a difference between the trial arms, which again confirms the safety of active surveillance. But for intermediate risk, there is still some caution. So there was an increased risk of metastatic disease in Dr. Klotz's series in Toronto. So if men with limited Gleason 3+4 decide to undergo active surveillance, they should be informed. They should be as part of a standardized protocol where they are informed about the lack of robust data and the increased risk of progression over time. When should men be offered treatment who are on active surveillance? Well, if they're reclassified to a higher risk disease, so Gleason score 7 or higher, or have significant increases in tumor volume, then we recommend therapy. So who are the optimal active surveillance candidates? Well, the jury is still out there, and this is the most recent guidelines from ASCO, from AUA, ASTRO, SUO, and from the EAU. And today, for most men with low-risk prostate cancer, active surveillance is the recommended management strategy. Some of these guidelines have caveats for younger men, African-American men, those with family history and high-volume Gleason 6, whereas other institutions would put all of these men on active surveillance. Select patients with low-volume intermediate risk 3+4 may also be offered active surveillance. And for those with a limited life expectancy, watchful waiting is more appropriate than active surveillance. The protocol can also vary depending on your institution, but in general, a PSA every 3 to 6 months, a DRE at least every year, and then the biopsy, we start with a confirmatory biopsy, a 12-core confirmatory biopsy within 6 to 12 months, and then every 2 to 5 years. It used to be more often, but that's been expanded in recent years, or if it's clinically warranted. This is what our schedule looks at MSK. We do surveys and PSA DRE every 6 months. We do an MRI every 18 months and biopsy every three years, or triggered by any of changes of the above. What about MRI or genomic testing, tissue-based genomic markers? Well, in the guidelines, they are still considered investigational in the context of active surveillance. They can be used when the clinical findings are discordant with the pathologic findings, and they can also be helpful when the decision to treat is uncertain. So, for instance, in cases of low-volume Gleason 3+4. The NCCN says about tissue-based molecular markers that there are no randomized controlled trials of these, but they're unlikely to be done. But they can be used because American men continue to under-select active surveillance, and physicians tend to under-recommend this treatment strategy because of uncertainty, and these markers can then help decrease this uncertainty. And they say that men with low or favorable intermediate risk may consider use of Decipher, Oncotype DX, Prostate, Prolaris, or ProMark as part of the initial risk stratification. Because you all know this, that there is a massive heterogeneity within the traditional risk grouping. So this is the classical Catan nomogram of progression-free survival after radical prostatectomy. And the tissue-based markers can likely help identify those who have a higher than average risk within their risk groups. The challenges with those markers are, of course, that we all know, the heterogeneity of prostate cancer, and they rely on small tissue sample, and that might be sampling error, so there is some heterogeneity there. So MRI, we do it at the start of active surveillance because it has a high yield for predicting reclassification. As you know, about a third or so might be upgraded at the initial confirmatory biopsy, for instance, anterior tumors that were missed initially. So it's recommended by all the guidelines that an MRI is performed within 12 months after the initial diagnosis. And you include both systematic and targeted biopsies. You don't do just targeted biopsies. But MRI cannot be used to replace the surveillance biopsies because there's no robust data that supports the use of that instead of repeat biopsy. And this is data from Memorial showing again this concept of that you cannot exclude the systematic biopsies because you have a 1 in 10 miss rate if you only do targeted biopsies. And this is the same that Dr. Klotz's ASSIST trial confirms that you should still do the systematic biopsies. And again, experience is needed with the targeted biopsy to make this accurate. How do you deal with patient anxiety on active surveillance? Because it's common for men to want to get rid of or cure the cancer. I want to leave it alone because it might spread. I want to get out of it. It's a common reaction, cut it out if I can. So at Memorial, we see some anxiety initially, but over time, we see that patients adjust to being on active surveillance because they feel safe and secure in the program. So they actually report lower levels of anxiety 2 years out. Another thing that's changed recently is the new risk group or the grade group system. So we've changed the nomenclature from the Gleason scores to the grade groups. So instead of this categorizations, we have the 1 through 5, which makes it easier to communicate to patients that your risk is low when you have a grade group 1. Another interesting concept is that developed by my colleague, Dr. Befara Day, in collaboration with Deepak Malhotra from Harvard Business School. They developed a systematic approach to counsel men to choose active surveillance based on framing principles from social psychology and behavioral economics. So if you're interested, you can get access to the slides afterwards, and you can go online and read the supplementary material, which gives you some talking points and how you can use your words to improve the uptake of active surveillance where you find it's warranted. So one of those principles is you shift the conversation from positions to interests. So instead of talking about, should you choose between treatment or no treatment, you talk about the interests that the patients might have in mind. Another thing is that you establish credibility. So if you say as a surgeon that I'm a surgeon and I believe surgery is beneficial in many cases, I don't think there's a benefit to you and I would recommend active surveillance. That's a very powerful principle. And using these principles actually increases the use of active surveillance by teaching this to surgeons. So in conclusion, Dr. Scarino has really solved Whitmore's dilemma, the right operation for the right cancer in the right patient at the right time. So we do active surveillance when cure is possible but not necessary, or else we have a multimodal therapy to cure when it's possible and necessary. Thank you.